Welcome to our session. My name is Martin Richel. I work for Linet as a global clinical research manager, and it's my pleasure to invite for our lecture and welcome warmly three excellent speakers. We have here with me Dr. Michael Otáhal, head of ICU department in General Teaching Hospital in Prague. Next to him is Dr. Nick Milček, who is leader of experimental lab of physiology in Charles University Prague. And in Sao Paulo, we have a world-leading expert in pulmonology and electric impedance tomography, Marcelo Amato. So now I would like to ask organizers to run our first lecture video.
Hello, everybody. My name is Michael Otáhal. I'm head of ICU unit of Department of Intensive Care and Anesthesiology in First Medical Faculty and General University Hospital. Today we will talk about protective ventilation strategy, about optimization, and about individualization of mechanical ventilation. So what is protective ventilation? We have to protect from ventilator-induced lung injury. We will talk about some strategies of protection, some studies. We have to minimize damage of the lung tissue by mechanical ventilation, but also we have to minimize the impairment of hemodynamics. But this is another story, and we have no long time for that today. What does it mean, optimization? Optimization of delivery of oxygen and removal of CO2. We have to individual set the mechanical ventilation, individual set of Peep, and individual set of position of the patient. This history, this screen shows the history of ventilator-induced lung injury. The name was first described by Parker in 1993, but in 1973, Kumar described barotrauma as the first describing a lung injury of mechanical ventilation. Then Dreyfus described the volumotrauma, overdistension as a damage of the lung. Then Slutsky brought us the model of atelectotrauma on biotrauma. It means opening and closing and reopening of the alveoli as a damage. And next, Marini in 2016 described ergotrauma or energotrauma, and then the concept of mechanical power was described by Gattinoni. On this screen, we can see the light blue boxes, which is established right now as an evidence base of medicine. We will talk about long way to prove low tidal volume as a standard of care, appropriate PEEP level, and prone position. Here on this picture, we can see the 4 study before 2000, which show us only Amato reduction of mortality with low tidal volume. Then the big ARMA study, breakthrough study, when they used 6 milliliter per kilo against this time used 12 milliliters per kilo, safety limit of pattern pressure 30 against 40, and allowable combination fraction and the PEEP. From this time, because ARMA trial showed us the huge reduction of the mortality with significance on this picture, you can see from this time the ARMA study and this RDS net ventilation is established as standard care of ventilation modes. Effect of PEEP on mortality on ARDS patient. Not single one of these studies showed the benefit. Alveoli, LAFs, Express, alveoli and Express was stopped before the end because the futility, and LAFs show us no significant difference between high and low level of the PEEP. Then the Braille in JAMA in 2010 described or meta-analyzed the raw data of the patients from these next 3 studies, and when the patient mechanical ventilation used higher PEEP in patient only when the patient with index PO2 below 200. They show us significant benefit for mortality. And from this year, since 2010, the higher or appropriate PEEP level is considered as a standard of care. Driving pressure by Professor Amato showed that we have to use pressure inside the functional lung size. Driving pressure is calculated as a plateau pressure minus PEEP, and they recalculate the data from the 9 previous reported randomized trial and show us, this is the trials used, and show us that if first day of mechanical ventilation, we use driving pressure, and when the driving pressure rise up, the mortality rise up. When the driving pressure is the same at a different PEEP of level, it means different PEEP, different peak plateau pressure, the mortality is the same. Driving pressure the same, mortality the same. And when we reduce driving pressure, maybe by adequate PEEP, then we reduce mortality. So from this study showed the higher plateau pressure is not always risky, only when we use higher driving pressure, and higher PEEP is not always protective. Safety border or some threshold of driving pressure, which can bring our patient safety and reduce the mortality, is below 15 centimeters of water. In 2016, Professor Gattinoni showed us with this paper mechanical power. Mechanical power was calculated and measured, was calculated by this defined equation, and show us that the mechanical power putting inside, the energy putting inside the lung tissue is most significantly dependent on volume, flow rate, and driving pressure, less than respiratory rate and less than level of the PEEP. It depends on pathology, more is low compliance and less significant resistance. Threshold or some borders of mechanical ventilation or mechanical was established in some study. Analyzing of these of patients from accuracy and ProSEVA trial, Guerin show us the huge difference on mortality when the driving pressure threshold is set to 13 and driving mechanical power threshold is set to 12. You can see the difference in Kaplan-Meier curve. We take driving pressure as a goal of mechanical ventilation, or is only a marker of severity? On these big studies compared, only reduction of the mortality and benefit in the patient show us the study where the driving pressure was reduced significantly. It means when we use some ventilate the patient and the driving pressure is above 15 centimeters of water, it means we have decreased compliance. We should strictly limit the volume to 6 milliliters per kilo. We maybe can perform some recruitment maneuver and optimize the PEEP, and we can apply some proning position, maybe with the blockage, neuromuscular blockage. Before 2013, before ProSEVA trial, there was no clear if the prone position had reduced the mortality. In this study of the meta-analysis, the previous trials, there was no significant difference between the patient in the prone and supine position. Only when we take the subgroup of the patient with PO2, FiO2 fraction below 100, it's mean right now severe ARDS, but it was before definition, Berlin definition of severe ARDS. But in this group on severe ARDS, prone position had some benefit, significant benefit of mortality. Then again, broke through trial, ProSEVA trial, that brought us information about a reduction of the mortality with proning. They start the prone position, the patient in the index, PO2, FO2 below 150, and with fraction above 60%. They use the standard define ventilation by ADS network. So they use the threshold and start the proning position very softly, 10 PEEP and 60 fraction. And what is important, they prone the patient at least at 16 hours per day. And they show up, brought the information about a huge reduction of the mortality, significant reduction of the mortality. And from this trial since 2013, proning position is considered again as a standard care of patient. Not only prone position, but always the semi-prone position or lateral position can help us or help our patient. If we have some asymmetric damage, injury of the lung, as can we see on this CT, we can put the patient with injured tissue up, maybe better in this semi-prone position. You can see the effect of the semi-prone or lateral position in our patient X-ray picture in admission of our patient. Then we start the ventilation. You can see the huge infiltrate on the right side. After 24 hours of positioning, we improve the right side like this. And after 20 or 48 hours, the improvement was significant. This is image of this patient in the lateral position. Open the lung and keep it open. It's a basic concept how to define or set optimal PEEP, described by Professor Lachman in 1992. When we have some closing alveoli, damaged alveoli, injured alveoli, we have to use some time and some opening pressure to reopen this closed alveoli. We can use some recruitment maneuver. Then we have to reduce airway pressure, and we made a PEEP titration to find some closing pressure when we some identification of reduction of oxygen or compliance identified the pressure when the alveoli are closing. Then reopen the alveoli and put the PEEP above the closing pressure, and this is optimal PEEP. On this video, you can see here in this part, reopening and closing through the every breath. It brings ventilator-induced lung injury in this tissue. This is somewhere here in the border between ventilated and non-ventilated tissue. When we perform recruitment maneuver, you can see there is no collapse, opening and collapse, but here in this position, we can see that take a lot of time. It's dependent on time to open, reopen the alveoli. So we, by recruitment maneuver, can open the lung here, but here on upper part, we over-distended or hyper-distended alveoli, and we can make a volume trauma. So what does it mean optimizing of mechanical ventilation? We have to or should prevent of ventilator-induced lung injury by minimize mechanical power, by minimize driving pressure. How? Maybe by homogenization of ventilation, we maybe can perform some recruitment maneuver. We have to optimize of PEEP by PEEP titration using some imaging, CT, ultrasound, some global parameters, compliance, oxygenation, PV curve. We can analyze stress index. We can optimize PEEP by volumetric capnography, by titration of transpulmonary pressure, and measurement of esophageal pressure. But now we have excellent method how to do the best way. Best way is optimizing of the PEEP by electrical impedance tomography. Electric impedance tomography brings us the information, global information about ventilation, some information about distribution, but the miracle is that we can see what's happened online into the lung, breath by breath. Peep titration by AIT is the tool of the AIT which can analyze the compliance, hyperdistension, and collapse. We can analyze the global parameters as compliance, hyperdistension, and collapse, and describe or choose one of the Peep, in this case 12, as optimal. In the graphics we can optimize here, but better, and it's beautiful on Peep titration or AIT, is this history shown. When we reduce step by step the Peep and make the Peep titration, we can identify the over-distended alveoli and the alveoli which start collapsed. We can choose again the optimal Peep with minimal collapse and minimal hyperdistension, here in this case 15 approximately. So we can see overdistension and collapse of our patient. This is Peep titration of our patient. Step by step we reduce the Peep, and you can see the asymmetry of hypertension or hyperdistension and collapse. On the right side hyperdistension, on the left side collapsed. Optimal Peep is somewhere between, level of 12. And again, next Peep titration, you can see more homogenization of lung tissue. There is no huge collapse, there is no huge overdistension, and again we can decide the optimal Peep as a 12. Automatic lateral therapy is the technique of Lynette company, which can provide tilting of our patient by predefined degree and the time. And the difference when we have the patient or the possibility how to use automatic lateral therapy, if we have the patient with this asymmetry damage of the lung tissue, hyperdistension on the right side, collapse on the left side, at 12 Peep, we can decide that we put the patient with left side up, with damage or collapsed size up, and after 14 hours of ALT on the right side, right, 30 degree, and the back, every position for 60 minutes, we can see the huge difference on the same level of the Peep, that we can only by tilting homogenize the lung tissue. And we can reduce the hyperdistension, reduce the collapse, and improve the compliance. So, what is protective? Protective is individualization of mechanical ventilation. We have to use some safety limits, safety borders, 6 milliliter per kilo, peak pressure below 27. We have to minimize driving pressure if it's possibility. We can calculate mechanical power, maybe concept of mechanical power bring us into information if we need to increase the mechanical minute ventilation in our patient. We have to increase respiratory rate, then volume tidal. We have to optimize of the Peep by some homogenization of lung tissue, some aeration. We should perform recruitment maneuver, but more better way is use some positioning, and it's our main aim and the future, the right position of the patient. It started with prone, and maybe by EAT we can target the position better right now because we can see inside the lung what's happened. So the last picture, there is no optimized setting, protective setting of mechanical ventilation without right position of our patient. Thank you for your attention.
Welcome to this short session on body positioning during mechanical ventilation. We will focus on principles, we'll focus on how positioning is important in mechanical ventilation. My name is Nick Mocek, I'm from Charles University. I'm mainly researcher, physician, and we run research on lateral positioning for many years. And in a few minutes I'd like to tell you what we've found, so I hope I succeed. We all know that body positioning in mechanical ventilation is very useful, and we know it specifically these days. This is the situation. Prone positioning has been proven to help tremendously in mechanical ventilation. So we know that's important. If we ask, why is it important? How does it work? This is less clear. Today, here, we will not talk about prone positioning, but we will talk about how lateral positioning works and how it affects mechanical ventilation and maybe what are the principles behind it. So we will talk about, we will have here live demo of real-time monitoring of ventilation during body positioning, lateral left and right tilt. We will then try to understand what are the principles behind these events, and at the end we'll try to draw some implications into clinical practice, how that can be used for the good of patients. So let's see live demo first, so that we know what we're talking about. And the live demo will be a real-time monitoring of the effect of the position on the lungs. How can we see the lungs? Well, of course, CT image is a very nice way how to see what's happening inside the lungs. However, it's static offline, we need to move somewhere, it requires transportation, it shows us only anatomical picture, not real breathing. It's radiation, of course. So we will show you different device here, which is electrical impedance tomogram, and it works like you see on the screen. So it's real-time 2D image, similar anatomy, left and right orientation like CT is, but it shows us where the air goes. As you see, anatomical detail is not great, but functional image is enormous. We see that in this case, only one lung breathes properly and the other one so-so. We'll need a device called electrical impedance tomogram. It's next to me here. And just to let you know, this tomogram can generate this 2D image. It also can generate and will show us a simple spirometry curve that you know from spirometry, from other devices. This is volume over time. We will have it on the screen, so I'd like you to appreciate that there will be graphs of volume over time, volume increasing vertical, and we will have separately left and right lung. And additionally, we will not see today, EIT is capable of showing perfusion. So imagine we could measure ventilation perfusion in real time. It'd be a dream. So I have a healthy volunteer whose name is Matthias, and he's here with us just to share his ventilation. So now we see his breathing on screen of tomogram. Let me switch to simple screen first. So that's a simple view, the simplest we have. So dynamic image, I'll ask Matthias, could you breathe in and hold your breath? So he's holding his breath, we see he's holding his breath. And then I resume breathing. You can breathe again, and he breathes again. At the bottom we have a spirogram with one big breath, which he was holding the breath. So this is how fast the system responds, instantaneously. So that's the device which we will use now to see what happens with ventilation and body positioning. At the moment, we see that the distribution right and left is 49-52%, which is perfectly okay. Since we will be comparing left and right lung, I will now switch to left and right lung view. So what we see now is, again, the distribution 48-52, a smaller transaction, smaller tomogram, and three big graphs. The top one is global impedance, middle is right lung, and bottom is left lung. So we see that both lungs now breathe very similar. And now, what happens if we tilt the patient to one side? And now it's 30 degrees tilt. On the tomogram, in real time, we can see there is a change in volume over time. So the middle line is the right lung immediately gains volume. The other one, the left lung, as you see, has lost volume. So immediately doing this, we have changed volume of one and the other lung by about volume of tidal tidal volume, tidal breath, so 300 mils, maybe 4, 3, 2, depending how much we breathe at the moment. So we have now opened one lung a bit. If we go the other side, guess what happens? Now we're moving back, and we will go the opposite side. So it's not mentally too difficult to assume that it'll be kind of opposite, and it is kind of opposite. Again, instantaneously, right lung is now losing volume, the bottom one. The top lung, the left lung's gained volume. So these minor changes, which we thought in the beginning of our research years ago that would do nothing, they actually offset the ventilation by more than tidal volume, maybe. And this will be different depending on patient status, healthy, sick, ventilator setting. If he was ventilated, he's not ventilated, he's a healthy volunteer. But for ventilation, again, these principles will be similar, but result will be different. So that's very nice to have a tool that tells us at bedside immediately what's the effect of our maneuvers. If there was no gravity, like in the space, our lungs, this is transection of the lung, would be nicely, evenly distended. So the red and blue circles are representatives of alveoli, of course magnified, just a simplification of alveoli in right and left lung. Right lung blue, left one red. Would be identical at zero gravity. At normal gravity, the bottoms are compressed a bit by the weight of the lungs. Lungs are not very heavy, but still they do compress the bases. So bases are smaller. At the same time, it implicates that tops are stretched a bit. So there is some non-uniformity. And if we tilt, the non-uniformity is even greater because, of course, the vertical gradient is more. So the bottom is even more compressed. Now the left lung will be compressed even more, like we saw in the demo, and the right one is more stretched. And this goes very well with classical physiology that you know from textbook from decades ago, where the gradient of pleural pressure is about 8 to 10 centimeters water in standing or sitting like you are, sitting body. So that's normal effect of gravity for normal lung. Imagine if the lung was ARDS lung or edematous lung or pneumonia, it becomes heavier, the compression forces are greater, the stretch is more, and the vertical gradient will be even a lot more in affected lung. And again, now let's compare to the normal lung, which is lateral tilt, not 40 centimeters, but maybe 20 to 30, so the difference will be maybe 5-6 centimeters of water pleural pressure, which means the pressure on the now right lung on the top is 6-7 centimeters different to bottom, which imagine in your ventilator you change P by 6 centimeters. It's quite a lot. It's not nothing. So this little or not dramatic maneuver, which we actually do every day, could generate several centimeters of additional transpulmonary pressure. Plural, hence transpulmonary pressure. And a lot more in ARDS. What can we conclude? Tilt can act as targeted, regional, left or right, or actually bottom or top, depending how we move the patient. Change in pressure. Maybe PEEP, maybe transpulmonary, whatever you want, but it's change in pressure, targeted in order of 5-10 centimeters water. This is a lot more than we had expected. Now, another implication is the change in pressure. We spoke about distension. Now, how about ventilation? What happens with ventilation? And ventilation distribution. Well, here we have, again, classical physiology curve of pressure volume curve, mechanical properties of the lung. Top alveoli are stretched, so they are near the top of the curve. The bottom one are compressed, so they are near to the bottom of the curve. So one are bigger, the other is smaller. So this is clear. What is the implication for breathing, for tidal volume distribution? Well, those on which will breathe more, which will get more share of tidal ventilation. Will it be top lung or bottom lung? Try to think a second. If we breathe in, which lung gets more air? Okay? So since the top one is more distended, hence less compliant, it'll probably get less ventilation. The bottom one is compressed, but potential for compliance is great. So it may get more ventilation. So surprisingly, the bottom lung will ventilate more. And this is identical what happened here when we had Matthias' demonstration. So let's see that from the record. So what you see here in the graph, again, global compliance, right lung, left lung. So the right lung at one time started losing volume. Probably when it got to the bottom. But if you compare the amplitude of this, the amplitude of right lung at this moment is a lot more than the left lung at this moment. So though it lost volume, it gains ventilation. Again, without having the device like the ATI, we would not know. But I'd like to comment here that ventilation is not identical to aeration. If we see nice CT or X-ray image of a nice aerated lung, it does not necessarily mean that this lung ventilates. It can be overstretched, overdistended, and may contribute to VQ mismatch. We should bear in mind. Okay, what are the clinical implications? So end of demo, clinical implications. So asymmetrical pneumonias. We have many with COVID, we have very many. We have, majority of patients are asymmetrical affection. Surprisingly for us, for Michael's hospital, is left lung a lot more affected than the right lung. We don't know why. Now, what do? We have a patient, asymmetrical disease, hypoxia, getting worse and worse and worse. We get oxygen, worse. So NAF, worse. Ventilator. What do we do with the ventilator? How do we set the ventilator? What is our hope? Well, our hope is to get more oxygen. However, at standard setting of ventilator, it will deliver the tidal volume into these asymmetrical lungs in very asymmetrical manner. If we run PEEP titration, if you remember, so for different PEEPs, you find which is the least hyperdistension, least collapse, hyperdistension in white, collapse in dark blue. Which PEEP is the best? Which PEEP has no hyperdistension, no collapse? Well, clearly there is none. If we ventilate these lungs, one lung, the good one, will be so compliant that it will always get most of ventilation, so it will be more and more and more overdistended, while the other one, the collapsed one, still does not open. Because the air goes where it is easy to go. It's easy to go to the good lung. So by this strategy, it's quite difficult to targetedly send the air into the bad lung, into the affected lung. Okay, well, I'm sure you know what I mean. And the suggestions, yes, tilt. Tilt so that the more affected lung gets on top, where there is more distension pressure, and the better one gets a bottom where there's some compression, which we don't care because this lung is so good that some more compression will not kill it, probably. So again, the similar principle, one gets stretched, the other one compressed, not collapsing fully. That's the trick, how with the one ventilator, one endotracheal tube, not biluminal, but single one, we can redirect flow or air and pressure to where we want. Targeted therapy. And this is a case of the patient From day one, we put the patient on alternating lateral tilt, only one side, actually right down, and day 3 and day 4, and we're happy. We conclude that tilt helps homogenize asymmetrical ventilation. Homogenize asymmetrical ventilation. We didn't have to play with Peep.
Většinou tak to pozdravuju, že jako se moc těším na tu schůzku, kterou jsme si domluvili. Teď jsem to stal, Martin. Bych se radši usmíval. Thank you.
Thanks.
Thank you for watching.
Okay, we are waiting for a third lecture now from Professor Marcelo Amato. This is the third video lecture.
Good afternoon. My name is Marcelo Amato, and I'm going to present this talk about bed positioning to enhance lung protection when gravity matters more than Peep and tidal volume. Gravity is everywhere. If you are on the surface of Earth, you are going to be attracted to the center of Earth. Every organ inside our body works as potentially as a liquid body, like the lung, where the superimposed pressure is going to work. So even small animals like this rabbit has big problems with gravity. This is his lung surface, the diaphragmatic lung surface. And this is a 3D reconstruction. I'm inside the belly looking at the head of the animal. And when we remove airway pressures, this lung collapses completely. And this is the strong effects of gravity. If you're laying down in supine positioning, your dorsal parts of the lung are going to be squeezed, and you are going to promote some negative pressure in the pleural space in the ventral parts of the lung. If you're laying down in prone positioning, you are going to compress the ventral parts of the lung. And if you're laying down in lateral positioning, for instance, this right lung is going to be compressed while the left lung is going to be overdistended. So this is a patient in lateral positioning, and this is the right lung and left lung. And you are going to see that when we are removing CPAP, this patient suffers progressive collapse of the right lung, as you can see here. So this lung is almost completely collapsed, while the left lung is still overdistended. So this is an X-ray of a patient. So you can see that the organs inside the abdominal cavity are pushing the diaphragm upwards. This lung is being compressed, while this lung is overdistended. The diaphragm is a much more caudal position, and this lung may be overdistended. Coming to our scenario of COVID patients. These patients stay in the ICU for a long journey. We know that the majority of these patients stay under mechanical ventilation and weaning phase for 3 weeks. And some papers are showing that if you take compliance, static compliance of the respiratory system, and this is days from intubation, so this is 2 weeks, there is a progressive decline of compliance along the time. And this explains pretty much the problem that we have with these patients, that sometimes they are classified in 2 phenotypes, and they have progressive deterioration of compliance along the time. And one of the reasons for this deterioration of compliance is because, among many other factors, and besides lung fibrosis, this patient developed a massive collapse in the dorsal parts of the lung, depending on your Peep strategy. This is a patient from our ICU. The problem of massive atelectasis is that to reverse atelectasis, as we know from the results of the ART trial, if you promote an aggressive recruiting maneuver, you can increase mortality. Despite all the criticisms about this study, this is potentially true, and an aggressive recruiting maneuver can cause deterioration of the hemodynamic system. So In a recent paper published in Anesthesiology, our group has shown that mechanical ventilation per se, and even in patients with normal lung, mechanical ventilation can cause massive atelectasis, much more than what you could predict from the PEEP levels you applied in these patients. And these are patients with abdominal surgery. This is an EIT image. This is the CT after extubation from these patients, and we can see all this blue area was collapsed. And when we apply the proper PEEP strategy, we could prevent the collapse happening during surgery, and these patients had a much better lung function. How much PEEP we needed to counterbalance this lung collapse is shown in this graph. So this is body mass index, this is PEEP. We can see that when body mass index increases, there is a progressive need of PEEP, but you still need a lot of individualization, because some patients, they have different anatomy and they have much more collapse than usual patients. So you have to obey a specific physiology of that patient. So the end result is that when these patients, they have too much collapse, the driving pressure during surgery can be increased. Like in these patients, the average driving pressure is 13, while in patients in which we could prevent atelectasis, you can work with a very low driving pressure. If this is true for normal lungs during anesthesia, you can understand that patients with COVID, they have exactly the same problem. When we use EIT to titrate PEEP, we typically start from high PEEP levels where we have lots of overdistension shown in white colors here. And then when we go down with PEEP levels, we started to see some collapse. For instance, in this patient, collapse starts to happen at a PEEP level of 14 centimeters of water. And then as you decrease PEEP downwards, you see much more collapse. In this other patient in prone positioning, and in fact, I should display these images like this, because this is the bed and gravity axis is going from up to down. And this is why collapse is happening in the ventral parts of the lung, while overdistension is happening in the dorsal parts. And for this particular patient, PEEP levels of 14 centimeters of water are the ones that have a good compromise between collapse and overdistension. So in patients in supine, we have overdistension in the ventral parts, but when the patient is in prone, we see overdistension in the dorsal part of the lung. How much PEEP we need to prevent atelectasis? This is a patient in supine positioning, and typically we choose the appropriate PEEP when collapse is yet prevalent. So this is PEEP level in the x-axis, this is collapse along PEEP steps, and this is overdistension in blue. So typically we choose the ideal PEEP around this crossing point. This is a patient in supine positioning. This is the same patient in prone position when we started to see some collapse in the ventral part. And as you can see, for this particular patient, a much higher PEEP was needed to prevent lung collapse. Now, in a patient with asymmetric lung injury, much more injury in the left lung. The right lung is still in a bad shape, but much better. In this particular patient, when we applied high PEEP, we saw a lot of overdistension in the right lung. And then for this patient, when we promoted some lateral tilt in the bed, so right lung down, we started to see a big decrease in overdistension and then a little bit enhancement overdistension in the left lung. But in general, much less overdistension for this patient. Now a patient in supine positioning, a typical PEEP titration procedure, and this patient had COVID, lots of dorsal atelectasis, but interesting enough, after applying appropriate levels of PEEP, we still see a lot of collapse in the dorsal regions. As you can see here, we had only 39% of ventilation going to the dorsal areas of the lung, and we know that the normal levels for these patients is at least 50%. So when the patient is in supine positioning, typically we see atelectasis in the dorsal areas. When the patient goes to the prone positioning, you start the prone positioning in this way because of lung history, but along the time, what you see is that some progressive decrease of collapse in the dorsal regions and some collapse in the ventral parts of the lung. And now the trick is that when you turn the patient to supine positioning again, and you are applying enough PEEP to prevent collapse, which is not a very high PEEP, it's just the individualized PEEP for this patient, you can keep the lung open. So prone position is also a recruiting maneuver, and you have to use it in a smart way. So for instance, this patient, despite a recruiting maneuver, had still very little ventilation in the dorsal parts of the lung, you can see here. But then when we turn the patient in prone and then supine again, but using appropriate levels of PEEP, now we have a very nice ventilation. As you can see here, that we have a little bit higher ventilation in the dorsal lung. Applying this technique in COVID patients have allowed us to wean these patients from oxygen much earlier and from mechanical ventilation much earlier. This is the preliminary results of a protocol we are applying in our ICU, and this study is still going on. We have already 40 patients randomized. But what I would like to discuss here is a different strategy that we can apply at the bedside, in which you don't need prone positioning. It's a much more gentle and easy to perform maneuver at the bedside. And we have been studying these maneuvers in experimental models of ARDS. For instance, this is a peak, and then we have a supine positioning, lateral tilt, and then lateral tilt 30 degrees. Let's see the physiological effects of this maneuver. So this is a video, online video. These are the quadrants represented here in the EIT. And these two graphs are representing these two upper quadrants, and this is the dorsal regions of the lung. So this animal has very little ventilation here. Now we are tilting the bed, and as you can see, we have an increase in FRC in the plethysmogram of the regions which are in the non-dependent position, and in this case are the right lung regions, while I have a decrease in the plethysmogram in the regions that are going to be downwards. And as a result, you can obtain some recruitment in those regions that stay upwards. Let me give you an example. This is the CT of this animal. We implanted two pleural sensors in these animals, one pleural sensor in the ventral part, one in the dorsal part. This is the EIT image, and these regions marked here are generating these plethysmograms. This is the pressure collected directly from the sensor, and this is the calculated transpulmonary pressure, which means airway pressure minus surrounding pleural pressure. I'm going to show you the results of this dorsal wafer, okay? So when we tilt the animal, the right lung increased the FRC because there was an increment in lung volume, but the left lung decreased the FRC, as you can see here. So there is an increase in pleural pressures and a decrease in transpulmonary pressures, and as a result, lung volumes decreased. Let's see what happens with our pleural sensors. This is the direct measurement of the pleural sensor. So there was a drop in pleural pressures, meaning that this surrounding pressure is now more negative or less positive. As a result, the transpulmonary pressure that represents the distending pressures of the alveoli in those regions, they are going to increase. And this is exactly what explains why this blue line increased in EIT, because all these lung regions are now much more distended. So we tested this using CT, and first we built a box where we could tilt the animals mimicking this lateral tilt of these hospital beds that we have nowadays, and we put the animal inside the CT, and what we could show in this animal, first in supine position, is that this animal had a lot of atelectasis despite using appropriate levels of Peep in supine positioning. And then we tilt the animal in lateral position. And as you can see, we can see immediately some recruitment in this area of the lung. But when the animal was back to supine positioning, to our surprise, there was a very interesting recruitment in these zones compared with these ones. And we had some decreasing atelectasis also in the left lung. As you can see here, there was a decreasing atelectasis even in the left lung. This was very surprising. As you can see here, the air content in the CT, this is for the right lung, increased a lot during the lateral tilt, so this lung gets overdistended for the same PEEP level, but afterwards you have a recruitment effect that you can use in your benefit. Let's see the 3D reconstruction of this patient. We can see that after the procedure, so we tilt to one side and then we tilt to the other side. And as you can see, after the total procedure, your lung is larger. We have an increase of 3 centimeters in the lung size. And when we rotate the lung, you can see that some regions that were previously collapsed, they got completely recruited without increasing any PEEP and without promoting any recruiting maneuver. We just stayed at the same PEEP level, but rotated the patient first to the right side and then to the left side. As a result, this lung got bigger also, wider, and we can see many different lung regions that got recruited with this procedure, and this patient had an improved oxygenation. So lots of collapse previously, after the procedure, complete recruitment of those regions. The lung got a little bit longer, as you can see here, especially during the lateral tilt. The lung is staying in the non-dependent position, staying upwards, is the one that gets the higher distension, and during this procedure you have a lot of recruitment in those lung regions, staying in the dorsal part of the lung. The interesting part, and this is a surprise that we are now collecting new data from these findings, is that when you look at the behavior of the quadrants during this procedure, we can see that this quadrant had an increase in lung volume and a decrease in atelectasis. The same for this upward dorsal lung region. This region, in contrast, gets compressed, as we could predict, because now the weight of the heart squeezes this lung region. But something very interesting for us was to observe what happened with this lower quadrant, where we could see some increase in aeration, which was confirmed by EIT and CT. Which is the explanation for this finding? I think the explanation for this is related to the change in the abdominal content and the removal of the gravity forces compressing the dorsal part of the lung because of the shape of the diaphragm. This is a very new information, and we are collecting more data to report this in a very beautiful publication in the next months. So let's see the size of this effect. This is the lateral tilt, 30 degrees, that some beds that we have at the hospital now can easily perform this maneuver without any effort. So this is the increase in regional lung volume that we can observe in the EIT after the tilt. The other lung goes downward, but this is not causing any significant atelectasis, while this right lung is getting a lot of recruitment after this procedure. But now let's try to promote the same change in right lung volume, applying a higher PEEP level. So we increased our PEEP level from 14 to 22, and then, so this is lateral tilt, back to supine. Now we are increasing PEEP from 14 to 22, so this is PEEP. You can see in green here, the PEEP is 14, now upwards to 22 centimeters of water, and this was just enough to get exactly the same lung volume in the right lung. So the most striking finding of our studies is the following. When we are doing this very gentle lateral tilt, our increase in lung volume confirmed by EIT and by CT and by pleural sensors has the same magnitude as an increase in PEEP of 8 centimeters of water. So I think this maneuver, this very gentle maneuver, like a lateral tilt of patients, can be equivalent to an increase of PEEP of 8 centimeters of water at the bedside. So this was a very interesting conclusion of our studies, and we are now performing many clinical studies to demonstrate that this maneuver is very easy to apply at the bedside and collecting some clinical benefits. Thank you very much. I hope.
Welcome to live session question and answers. We have several questions, so let's start. First question can be a combination of two. What is the ideal time and angle for a lateral tilt for a patient? So, gentlemen, can you comment, or Professor Amato?
Maybe Marcel can start.
Oh, hello. Martin, are you listening?
Yes.
Yes.
Okay, sorry, I could not hear can you repeat the question again?
Okay, so what is the optimal length, time, and the angle for the tilt?
Oh, perfect. We have data showing that in 10 minutes, we have approximately 90% of the effects. So in some patients, just 10 minutes of lateral tilt is enough to get the result. But we have also some few patients in which we understood that they need repeated cycles of 20 or 30 minutes up to 1 hour to open the lung. And but typically we see a very remarkable effect after 12 hours or an overnight tilting of the bed. And I think other data that we have tested is different angles and the physiological effects. And I think 30 degrees is a good compromise. But we still see some very remarkable physiological effects with 20 degrees or 15 degrees. So if possible, I would go for 30 degrees where we see a good physiological effect. That's it.
Thank you. Any comments from your side, gentlemen?
Yeah, 30 degrees maximum tilt on the Lynette bed. So we use this maximum. And in our hospital, in our department, the standard protocol is tilting 60 minute 30 degree on the different size. If you have asymmetrical injury, we prefer supine and the injured side up. And when we have symmetrical, we tilt in on both sides.
Maybe short comment, I would like to stress what was mentioned here. If we go for personalized medicine, I think that's the way we want to go, then we probably will find different angle for different patient. So at the moment we go for 30 because it's max and we thought it was not enough, and we now know it is a lot, as you hear from Marcel. But in some patients, less may be perfectly sufficient, and 30 might be even too much. So that would be probably the future of medicine. Go more and more personalized, and monitoring by AIT plus tilting and ventilator allows this today.
Okay,
Very
thank
good
you.
comment. Very good comment.
Thank you. Another question. We saw the live demonstration on healthy volunteer. So question is there a difference between the healthy volunteer and the sick patient regards to the pattern of volume, ventilation volume, if I understand properly? And can also the tilt increase certain risks like aspiration pneumonia or gastroesophageal reflux.
Okay. Maybe I can start with the second part of the question. We have tilted the patient more than 4 years. It's very often on our department, and we have no significant increase in gastroesophageal reflux and any aspiration pneumonia. So I don't think it's worth the gastroesophageal reflux. And the first part of the question was different between volunteers and our ventilated patient, maybe.
Yeah, I can comment on this. So gravity acts on everybody similar way, but of course the situation is much more complex in ventilated patients who are probably ventilated for a reason. So as we mentioned before, with ARDS lung, for example, the forces are much greater. With application of Peep, you might see some different behavior, and also if there would be regional differences in the lungs, unlike for healthy where it's homogeneous, we might see different regional effect. So principles are identical, but depending on severity and regional problems, we might see different effects. And again, that's why individualized medicine is so important, because we don't see into the patient. Maybe Marcelo also has a great comment on this. I know they are running research on this, and I'm sure you have.
Yes, Nick, I think it pretty much depends on the PEEP level you're applying. We have seen that when we are using, let's say, a reasonable PEEP, the effects in mechanical ventilation and volunteers are matching, because the diaphragm is working as a, let's say, a reasonable PEEP for a sick patient. But what we have seen is that if you are using low PEEP, like 5 or 8 centimeters of water, typically the lung that goes downward gets too insufficient PEEP, and then it starts to collapse, and then you have more ventilation to the upper lung. So if you're applying a good PEEP, you should see the same things that you see in volunteers. So you have a little bit more ventilation in the lung, which is in down position.
Thank you. Exactly. Yeah, it's very nicely exposed. That's our experience too. Thank you very much. Yes.
Yeah.
Thank you. Another question is, if the tilting of the patient can impair the cognitive functions of the patient. Do you have experience with that?
We have no experience with any problem with cognitive function after tilting, so no comment for this.
Our patients are animals. No knowledge.
Martin, can you repeat the question? I could not listen the wording.
Sure. Do you observe any impairment of cognitive functions on patients who are tilted?
Oh, yes. We now I understood. Well, I think we don't have enough data for this. We don't see any special reason to see an impairment in the venous return. And then, at least from a physiological perspective, I don't expect any problem, but we don't have enough data on this.
Okay, thank you. Another question is there any special protocol for patients who are suffering by pathologic pain for a tilt?
It's normally stated as another patient. Everybody who's on ALT, automatic lateral therapy, is under sedation, so analogous sedation. So we use analgesic and use hypnotics. So I don't know about any special for COVID patient.
Martin, I have some data from a recent paper, a recent patient that we treated, and he was having a big pain because of a scar in the bottom part of his back. So he has the typical sacral scare because of decubitus. And he was telling us that when he was in lateral decubitus, this pain was alleviated. So I think it depends pretty much on the type of pain and what kind of skin problems the patient has.
Thank you for that insight.
We have no pressure ulcers on linen beds.
Okay,
so
thank you.
We have
thank you. I think this is the main way because of the great care of the nurses. Another question is the effect of lateralization causes a great overdistension. How to increase the P to 8? This is the question.
I'm not sure if I understand.
Me neither.
I
may lateralization causes a great overdistension.
This could be possible. This could be possible specifically in asymmetrical situation, asymmetrical injury. So supposedly your left lung is more affected. So already in supine position, the right lung will be overdistended. Now, if you turn on the left side, which is opposite to what we suggest, then in this situation, the better, healthier lung may be extremely overdistended. So that's what we probably don't want to do. So that's what I would get from this one. Yes, lateralization could cause significant unwanted overdistension, specifically in asymmetrical condition.
Agree.
Okay. Another question is, how important is prone position on patient with COVID-19?
Standard part of the standard care about this patient, but as we said, the main aim of our results or our research is individualize the position. What you can see on AIT, you can then optimize the position. Not only prone position is the best position. Marcel, any comment?
So I think in general, prone positioning has been very beneficial in patients with COVID, especially because this patient is going to stay for a long journey under mechanical ventilation, and sometimes it's unavoidable that the patient has some decubitus atelectasis for disconnections or for other problems that during aspiration. And then prone positioning is always a very good, effective way of recruiting the patients in a gentle way. And my understanding now is that, okay, having these new resources, this new tool, which is lateralization, maybe in some patients we don't need any longer to prone the patient to recruit. So we can use a gentle maneuver like this lateralization to help us to achieve the same goal. But it's my understanding that most patients with COVID, they have, let's say, massive atelectasis, which is adding to the hypoxemia problem. And then as much as we can, we should avoid this.
Thank you. Another question, can we combine increased PEEP and tilt position?
Of course.
We must combine a good PEEP with a proper PEEP with a proper position. That's something which took us years of research, because first we started with just the effect of tilt. If you don't combine tilt with a good PEEP, you may get no effect. And as Marcel said before, if you have too low PEEP, it will be behaving opposite. So I think this is a great question. We must bear in mind that tilting works very nicely, but on right level of PEEP. And how do you find right level of PEEP? It's similar story to even non-tilting case. But again, if you have a chance to see with the IT, it's much easier. If you follow your compliance or blood gases, this is also an option, but it's must. So very nice. We must have a right PEEP for right tilt.
Right position.
Okay.
Absolutely.
Okay, thank you. Another question. The pre-last. The superimposed pressure happens on both vertical and horizontal axes. Would this be one of the explanations for the new findings in the lung that goes down?
Can I answer this?
Please, yes, thank you.
We don't have yet a good explanation because this is a very new finding. But I believe that this is related to the weight of the abdominal structures. And so from the lung perspective, this question is very good because we should observe an increase in superimposed pressures. So only thinking about the weight of the lung. But because pleural pressures are driven by a combination of lung weight and abdominal content distribution, this is a little bit more complex than we were imagining. And I believe that this is the main reason why we have seen this effect. And you can easily observe at the bedside that some patients with a very prominent belly, the belly is completely, let's say, laying on top of the cushions. So this must mean that when we have the lateral tilt, the weight of the abdominal structure is not any longer on top of the diaphragm, but it's exerting some pressure now in the cushions in the bed and not in the diaphragm as previously. I think this must be the explanation.
Thank you, Marcelo. And we have a last question. Should there be a tilting protocol for patients with non-invasive mechanical ventilation?
We don't use automatic lateral tilting in non-sedated patient. So if a patient is on non-invasive mechanical ventilation, we can talk with the patient and ask for changing the position, not but tilting. We can have an agreement with the patient with non-invasive ventilation that left lateral position will be better for him or her, but non-invasive ventilation is not sedated patient, so not automatic tilting.
Thank you. Any comments from your side, Marcelo?
No, we don't have yet a good experience on this, but in principle, I think we should have the same physiological effects, but we don't have too much experience on this.
Thank you. So this is the end of our live question and answer session. Thank you very much to all attendees. We have maybe last one. Is it always the best to tilt certain patients even when they are in a prone position?
That's a nice question. Yes, it's also meaningful in prone position. I'm sure clinical gentlemen will have comments on it, but great question.
Marcelo?
Sorry, Martin. I have a main presentation here now in the Brazilian Congress, and so I have to enter immediately. So sorry for this.
Okay. Thank you for your participation.
Thank you.
Thank you.
Oh,
Bye.
it's my big pleasure. Thank you very much to all.
Bye.
Thank you.
So my answer, if it's dependent of asymmetric or symmetric injury to the patient. If you have symmetrical, maybe you perform prone position and it's better for the patient. When you have asymmetric, you can maybe choose the better way and intelligent way just to tilt on the right position, independent of titration, independent of collapse or hyperdistension. So we prefer tilting if we have asymmetric, and we usually perform prone position if we have symmetrical. But it's on the way, the research on this.
No, that's a very good question. Yes. Thank you.
Thanks.
So once again, thank you very much for all attendees. I hope you enjoy our session dedicated to patient repositioning guided by electric impedance tomography. We are looking forward to meet you again on maybe next year. And thank you and bye-bye.
Thank you. Thank you, Martin. Thank you, everybody. Thanks.